Today I'm excited to welcome Jonathan Ramsay, who has over 30 years experience as a consultant urologist and one of the leading UK urologists. Jonathan's helped thousands of men and couples on their fertility journey, so welcome, Jonathan.
David, thank you very much. I always hesitate a little when I hear that 30 years, but remarkably it's true.
Fantastic. Jonathan, thank you so much. I've got a couple of questions I wanted to ask you today, which I'm hoping yourself and the listeners will benefit from this with your expertise. Can you maybe tell us a bit about why you got into the field of urology, and in particular male infertility?
Well, getting into the field of urology, that's an easy question, David, because when I was training, and in those days we all trained as surgeons first, as general surgeons, urology was underrepresented as a specialty. It was quite exciting because we were beginning to use many more telescopes, cystoscopes, and beginning to adopt a minimally invasive approach. So there was technical interest, but if I'm being honest, it was also the case, as it was underrepresented, it was a little bit easier to become a consultant. As for fertility, well, this was before IVF and ICSI, so I was training in the 80s, and therefore we saw lots of men with subfertility, infertility, and then without IVF and ICSI, we actually tried to treat them. And so some of the treatments and the investigations that we are almost reinventing now were commonplace then. Treating men with varicocele was very frequent. And so I sort of got a feel that there was something that you could do. And in the last 10, 15 years, we've gone back, I hope, to that policy. There's
a couple of examples you gave there, particularly around the varicocele, which is a big one these days. How can a urologist actually help men with their fertility, and how long should a couple try to conceive naturally before seeing a urologist?
Okay, well, the answer to the second bit, how long, I think that's changing. If you look at the standard wisdom, the old-fashioned traditional wisdom, it's that particularly young couples should be allowed to try for a couple of years. But in fact, of course, I think as people are becoming more aware when they are younger that there could be a problem, they know many young friends perhaps who are having IVF, I think that time trying should be significantly reduced, probably really to about 6 months if you're young. Now, if you're a bit older, in your later 30s, then of course the same applies for different reasons, which is that if you are beginning to run out of time because of your age, then possibly you ought to get onto these investigations a bit quicker. I mean, we've got to be careful, we mustn't over-medicalise, and if you do investigations, you will find things that are wrong. Or worse, you may find things that you don't understand, that you can't quite explain. And that's particularly true of semen analysis because it's a biological system, open to variation. And so one semen analysis taken speculatively might, on the one hand, give an over-gloomy picture, and on the other could be over-optimistic. So one has to temper both the timing of the investigations and the interpretation, but the thrust of my answer is sooner rather than later.
You mentioned a moment ago about the age or the timing of the age. So I guess if you were in your early 20s compared to if you were in your early 40s, there's a big difference in terms of...
huge. Enormous difference. And of course, the age at which women are having their first child has increased enormously. And there was an Office of National Statistics report, I think only 2 or 3 weeks ago, that pointed out that over 50% of women had not had their first child by the age of 30. That's very significant. You look back even 20, 30 years, and that number would have been mid-20s. So this, this is a big change and has an impact on overall fertility entirely independent of male fertility.
Wow, it's interesting, just in terms of how different that could be.
Mm.
Wow. So if, for the men watching today, and I guess if they wanted to book in to see a urologist, what questions do you think are important for men to ask a urologist in their first meeting?
Well, I think it's important to explore all the lifestyle things. If the urologist doesn't ask the man, then the man should be aware of things that might be impacting on his fertility. There's several quite common things that spring to mind. A lot of exercise, too much exercise, getting too hot, wearing lycra, competitive bike riding, whether that be to work or at weekends. This may actually be counterproductive. Overweight, obesity, very important, and I think something that we've only just really realised in the last 3 or 4 years, because it's so difficult to prove relationships. Certainly nutrition and diet, the sort of lifestyle that many of us have, because that's the way it is. We work hard, we play hard, we don't sleep as much as probably we should. We get up early because that's when the work is about. And of course there's sometimes partying too hard and all the things that go with that. And I think that people, patients, men, should be asking urologists whether what they are doing could be impacting upon their fertility. Now, it's very easy for us to say, oh, well, you know, he's a young chap and he's got quite a lot of sperm. A few pints 3-4 times a week doesn't make a difference, but it may be making a difference. And of course, the stuff that goes with the 3 or 4 pints, various substances, it's a worrying statistic that many men, sometimes knowing it, but sometimes not knowing it, have been using steroids. They've got used to taking proteins mixed with steroids when they go to the gym. They notice that this allows them to have more muscle and less fat. And some of them become a bit addicted to this, and it can have a very severe effect on spermatogenesis. The elephant in the room, of course, is always smoking. This has a very bad effect on sperm quality, which may not be evident from the semen analysis, because, of course, the noxious substances in smoke and tobacco smoke damage the DNA that is in all of us, in all parts of the body, but in fertility terms, this is the all-important packet, tightly packed packet of protein, which is the DNA that will go to make 50% of a human being. And if this fragments, if it's damaged, then fertility is significantly affected.
Wow, there's so many different scenarios you gave in terms of what can damage, I guess, a man's sperm, and particularly the DNA around that helps support that. With the smoking and the drinking, are they 2 big factors?
Well, they often go together. The smoking is probably worse than the drinking, but I think the drinking probably creeps up on people a bit. You know, the Thursday night phenomenon, which might spread to Friday, and then a bit of a wedding on Saturday. It certainly can have an effect. The other thing I didn't mention, which some men don't think to mention, are the almost proprietary medicines for hair restoration, which are based on a substance called finasteride. And this usually works. So once again, the users are very pleased with the effects. and are surprised that this may be having an adverse effect on their fertility.
So with the smoking and the drinking, I guess in a little bit more in particular, by eliminating that from a man's diet, you talked about the diet element as well, would that improve the DNA quality of a man's semen by stripping out or by reducing alcohol, smoking, and you also mentioned, I think, excessive cycling? They all sound like they play a part in terms of...
It's a selection of marginal but compounding gains. And I think the interesting thing is that once all of us start addressing one habit with a sense of purpose, then quite a lot of other things happen too. And so the changed lifestyle, 6 months of changed lifestyle, may make a significant difference. You see, the other side of this lifestyle coin is I've got plenty of sperm. They may not look too good, but there are plenty of them. And we're going to have some IVF. So surely that's going to work. And therefore, as a man, I don't really have to bother. You know, we'll just produce some sperm. There are millions of them. Most of them are swimming. And okay, only 2 or 3% look normal. Surely that's okay. Now, of course, sometimes 30% of IVF and ICSI cycles, it is okay. But if it isn't, then men and their partners begin to say, well, perhaps we could have done something first. Because, of course, IVF, crikey, it's a marathon. Now, none of us would set off on a marathon. I mean, I would never set off on a marathon, even a 10th marathon. But even if it was a 10th marathon, I'd sort of do a bit of training. Because if I didn't, I wouldn't really expect to make it. And the same principle, I think, can be applied to some of these long fertility journeys.
There's a point you raised a moment ago around a man's sperm or semen, and just in terms of what seems quite adequate for a man to have. You mentioned millions of sperm, but is there like a percentage or a number that is adequate for a man in terms of what numbers look normal for his semen?
Sure. Yes is the answer. So, but we only get this information really retrospectively. A lot of it comes from fertility units, and a lot of it is historic. Because, of course, what has been happening over the last 40, 50 years is that sperm counts across the board have been declining. But if you take a number which should be associated with natural conception, a number, then it would be about 40 million, a density of about 40 million. But then you've got to look at the motility. So you can derive another number, which is a combination of the number of sperm, or the sperm density, with those that are progressively motile. So if you like, this is the dose of sperm that's getting to the egg. By and large, if you've got more than 20, 25 million progressively motile sperm, then that's should be a big enough dose to fertilize the egg. But then we've got to think about what is the payload of that sperm, and that comes back to the DNA, and whether there might be anything around that is preventing the sperm and the egg from actually docking, whether there's some inflammatory process that's getting in the way of that. So although you can talk about the numeric headlines, you've then got to look a little bit more closely at other things that might be frustrating that peloton of sperm that's making its way to the egg.
Mm. That's really interesting. And I think the point you raised around where the number should sit from a male perspective in terms of how many million sperms a man should have in terms of their success rate. What would happen if a man only had 5 or 10 million sperm count? Does that make a difference in terms of them being able to pregnate their wife or partner?
Well, broadly speaking, it does. But of course, here we are, we're all men in this room. We love numbers. And there's a terrible danger of reading a semen analysis like an Excel spreadsheet or a bank statement, where every number means something. But not only is this variable, but it has to be seen in the whole context, because you're talking of your man with 5 million sperm, let us say, 10 million, but his total motile sperm count could be not too bad if he has a high semen volume and he has good motility. So it may not be as bad as it looks. You do have to look at each part of it. And then, of course, 50% of the issue is the egg. So if you've got a tip-top cracking egg, it'll make up for a slightly wonky sperm. So often men will be terribly depressed. They look at their semen analysis result and it's way off the WHO, the World Health Organization norms. And not surprisingly, he thinks to himself, well, I'm so far off this, I can never be a father. And whether he articulates that to his partner or just thinks it, internalizes it, which is even worse, he has sort of decided in his own mind that he can't do this. And that's a terrible situation for a man to be in. And so I think one's got to spend some time putting their situation in context. The age of the lady, possibly their past treatment cycles, what's happened to him. And get several analyses so that you can get a feel for what's really happening.
Mm-hmm. That's interesting. So I guess ultimately, when we look at a man's semen, although that plays a part of it, the other part is the female's egg, because I guess it, and forgive me if I'm wrong, but does 50% of infertility now account for men?
Yes, I think it does. That would be a biologically sensible remark, and particularly so when the time at first trying to conceive has got later. So previously, if one was thinking of maybe 40, 50 years ago, certainly 60, 70 years ago, the age at first conception of most women, brackets non-working, was early 20s, even late teens. So therefore, quite a lot of disturbed male fertility would have been eclipsed by the extreme fertility of these young women. But the less benefit one's getting from the egg, then the more relevant the other 50% of the problem becomes.
Really interesting, really interesting. The thing I want to, something you touched on earlier, you mentioned the word varicocele earlier. From what I hear, recent research suggests that treating a varicocele can actually improve fertility by 50%, and you've already mentioned that could be correct. But how do men know whether they have a varicocele, and what does that mean?
Okay, so about 15% of men are born with a varicocele. This is a bunch of distended veins, and they can be distended quite considerably or less distended. But some of these varicoceles you can actually see. When men stand up, they might notice that their left testicle is apparently much bigger than the right. Well, actually, of course, when they lie down, their testicles are the same size, but when they stand up, the veins around the left testicle, it's usually the left testicle, distend, just like varicose veins in the leg that you see, in people on the beach. When they stand up, you see those bluish bunches of veins, which are varicose veins. And the same thing exists in 15% of men around the testicle. Now, in many of those men, it doesn't make any difference to anything. But in those who might be starting a bit subfertile, then it, if it's big enough, can tip the scales between subfertility, even infertility, and fertility. So, like so many things, it depends upon degree. Okay, so if 15% of men have one, then we have to ask the question, well, if you're having difficulties with fertility, what percentage of those men might have a varicocele? And the answer comes back 40%. So it is relevant, not to everybody, but to men who may be struggling, but not all of them. So it's significant, but it is not a universal linear relationship between the possession of a varicocele and necessarily being infertile or subfertile.
So 15% sounds quite a lot for a man to have a varicocele, but it doesn't necessarily mean that you can't conceive if you have one.
That is absolutely correct, and that is a very important take-home message. Now, of course, traditionally one measured the effects of whatever one had, whether a varicocele or some other cause of subfertility, just by looking at the semen analysis. And as we've already explored, this is a variable phenomenon, biologically dependent upon lots of things. But if you use the DNA quality of the sperm, the DNA fragmentation, as a marker, then you begin to perceive a nice male-orientated numeric relationship between the size of the veins, their diameter, and the degree of DNA damage. So that is a much more subtle indicator of the need for varicocele treatment than is simply semen analysis.
Would you recommend someone who's been trying for a while, they have a varicocele, to get it treated?
So only on the nice numeric basis of the size of that varicocele and its relationship to the DNA quality of the sperm, and indeed the couple's story. So if we've got a nice fertile woman under 34, 35, who should have got pregnant because there are plenty of motile sperm, then one thinks to oneself, has he got a varicocele? What's his DNA fragmentation? Can we improve the sperm quality to a point at which they may conceive naturally, but perhaps more importantly, as time is passing, they may even do a little bit better in their IVF or ICSI cycles.
I think for men watching this today, will probably be thinking in their minds, what does it mean to have a varicocele removed? And I guess is it a painful procedure at all?
Well, before we do that little bit of detail, one has got to balance, one has got to sense check this conversation with somebody like me who is fertility, DNA fragmentation obsessed. We've got to sense check that against what NICE says, what the fertility, not exactly police, but the fertility, the national NHS fertility advisors say. Now, of course, NICE will say that treating varicoceles makes no difference. This is a little bit out of date, but we mustn't knock them, because on the evidence of 10, 15 years ago, it was difficult to prove that varicocele treatment made a difference. But of course, if the starting point is that you don't treat varicoceles and that all the men are banged up in fertility units having IVF, then it's quite difficult to work out whether, if you treated it, which you haven't because you said it wasn't any good, there would have been a better outcome. So if we look at other guidelines from other countries, then both in Europe and in North America, the business of giving due consideration to a varicocele is now being included in those countries, those urological societies' guidelines. But the UK hasn't quite caught up with that. So it's important to have this sense check, because within the poor old NHS, suffering hugely with waiting lists after COVID, then the assumption that everybody's going to say, oh good, you've got a varicocele, let's treat it, that's not correct. And even if the guidelines are changed in the UK, which I suspect they will be, it's going to be jolly difficult to service this requirement in the NHS, because the priority isn't quite there, and we've got to catch up with all the surgery that hasn't been done. So this conversation at quite a high level does need a sense check, a reality check. And you know, if we were speaking to an experienced fertility gynecologist, a man or woman who runs a fertility unit, they'd say, oh, well, you know, it might make a difference, but surely the right thing to do is just crack on and do the IVF. And in a sense, if you can get the IVF quite quickly, then both the man who perhaps doesn't want an intervention and the lady who really wants her treatment as soon as possible, they might go along with that. And, you know, in certain circumstances, that's not unreasonable.
Can you make a difference?
Yeah. I think we, not particularly me, but I think we can make considerable differences. The first difference is to take it seriously, because the worst thing for a bloke is to have a semen analysis with a lot of numbers on it, and he says to the doctor, well, surely this isn't normal, you know, I'm way out in every category. And the response is, well, that doesn't matter, just have some IVF, you know, that'll sort it out, we'll choose the best sperm, so don't worry. But then he thinks to himself, well, all right, that may be true, but I'm still a little bit concerned, why is this? Number one, could it be better? So an explanation and taking those results seriously, as we do in medicine in other ways, you know, you have a full blood count, your red blood cells, your white blood cells, if they're off the scale, doctors don't say, oh, well, don't worry about it. You know, eat the iron pills, that'll sort it out. You know, we try and find out what it is. So I think the first way in which we help is to take it seriously, to consider it, and to try to make a diagnosis. And even if we can't make a diagnosis, we can give an explanation. That is very comforting. The next way in which we help is that we don't give the impression that this is hopeless and the only way forward is IVF, because that tends to further emasculate the bloke, and he thinks, well, you know, not even worth having sex then. And then, of course, the consequence of believing that it isn't worth it is that you don't do it. And, of course, doing it is one route to a pregnancy. So unwittingly, the medical profession, by just saying, don't worry, ICSI will sort it out, we're beginning to cause, maybe causing some psychological problem. Unwittingly, we don't take it seriously enough. So first, we can help by taking it seriously, then by investigating it, then by explaining it, and I would say in 50 to 60% of cases, making it better. Now, we may not be converting 50 or 60% of those couples into a naturally fertile couple, of course not, but we may well be adding to the live birth rate, but I think we are also smoothing the pathway, helping.
Yeah, really, really good points you raise, Jonathan. I mean, generally, how do you cope?
How do men cope? Yeah, well, I think one's got to try and help them to cope. And it all depends, or it may depend upon what stage we're meeting the men. Are we meeting them right at the beginning of the journey, when the very worst thing is a diagnosis of no sperm at all. This is devastating, and it's often been delivered quite casually. It may have been delivered by a GP's receptionist or a brief telephone call, just saying, you haven't got any. And the man says, what, no sperm? And the voice comes back, well, none. So the chap says, well, why? Well, we don't know. You just haven't got any. Now, the impact of that one test and that one result on that man, it's almost as bad as a cancer diagnosis. Now, in fact, in some ways, without any further explanation or prospect of help, it's worse, because it seems to be so binary. And if one thinks about medicine, you can have other diagnoses, even a cancer diagnosis, but it's not that you're going to die. There are many, many things that we will do to intervene, and probably you're going to be all right. But with this no sperm diagnosis, it seems to be final. That's it. So how do we help people to cope? Well, we, all of us, from medical students onwards, I think have got to learn the significance of this particular diagnosis, because if you get off to the wrong foot, the poor man isn't coping from the moment he hears that. So the next stage at which we may see people is, of course, when they've just got the low sperm count. Now, then help them to cope by explaining that this is not a non-starter, that in their situation, bearing in mind the lady's age and things that he can do, that there may be some improvement here. So for heaven's sake, don't stop having sex. Let's work at it, so that once again, he doesn't feel emasculated. Because what happens up and down the country with the low sperm count is 2 years of not having a baby, 18 months of not having a baby, low sperm count equals IVF. And the equals IVF has the same impact as I was saying earlier. It's, well, in that case, let's not bother. Worse, let's put our faith in the IVF. And then, of course, it doesn't work. And then that is all my fault, guilt, why me, all those really negative things which make people miserable and very unhappy. So the second thing is to manage the low sperm count diagnosis. And then, finally, we're getting on the journey now, to manage the failed cycles of treatment due to presumed male factor. Because that then has reinforced all that negativity. And somehow one's got to draw back from that and try and get the couple together again often.
Yeah, I think there's so much there that I think for men need to really kind of get to understand how it all works, and seeing an expert in the first place to help them on their journey. And it's something that you particularly are very interested in terms of helping couples on their journey. So thank you so much for that, Jonathan. If you could give one tip for men watching right now, what would you say to them?
Okay, so firstly, just don't despair. Secondly, try to get a plan. So a plan for themselves, a plan for the two of them, so that they have a plan that gives a sense of purpose in an otherwise apparently hopeless situation. So we are going to work towards better fertility. We may or may not be entitled to a cycle of IVF, but when we get there, we will be better than we are now. We are not going to stop having sex. There is some data, I wouldn't go so far as to say evidence, because we're in a kind of evidence-free zone with fertility, but there is some data that actually sperm quality improves with more frequent ejaculation. So I think it's about having a plan. It's not about false hope, but it's seeing the journey ahead and having somebody to help them to visualize that journey so that it doesn't fall into hopelessness.
Jonathan Ramsay, thank you so much for your time today. You've given us some invaluable information, which the men watching today hopefully will take on board and listen to some of the advice that you've given today. So thank you so much for being with us today.
Well, David, I want to thank you because it's relatively rare for a man to involve himself in this conversation, so I thank you. I know there are a few others with whom you are in touch, and you're all getting in touch, and I think this is a great thing. At the moment it's a movement, but it would be nice if it was a revolution. So thank you very much, Dave.
Thank you so much. Thank you.